Functional neurological disorder, or FND, has been called a silent epidemic, a crisis in neurology, and psychiatry's blind spot. And I have to admit, this diagnosis has been a huge personal blind spot for me. I, like many Americans and healthcare providers, knew nothing about this condition before I read this paper. Luckily, others in the OT community have been hard at work standardizing care for FND patients. Multidisciplinary treatment of functional neurological disorder, including referral to OT, is a best practice. And today, we will look specifically at expert recommendations for OT assessment and treatment. After we review these recommendations, we will welcome to the podcast Naoya Ogura, OTD-OTRL. Naoya works as the West Los Angeles Clinic Director at Reactive and specializes in neurological conditions like POTS, EDS, MCAS, and FND. So let's dive in. Welcome to the OT Potential Podcast, where we review new and influential OT journal articles, then invite on an expert guest to help us pull out actionable takeaways that you can implement in your practice starting today. Welcome to the podcast. I'm your host, Sarah Lyon, OTRL. And before we dive into this big topic of OT and FND, I wanted to let you know that this podcast may qualify as continuing education for you. You are probably listening to this podcast on a free podcast platform, but to gain CEU credit, you will need to be a member of the OT Potential Club, our OT continuing education platform. So bearing in mind that this could count as a CEU course, I wanted to state our two learning objectives so you can be thinking about them throughout the podcast today. Our first learning objective is you will be able to identify components of OT assessment for functional neurological disorder. And two, you will be able to recognize recommended OT treatment interventions for FND. So let's begin by looking at our journal article, and then we will bring on Naoya to discuss how this could play out in your practice. The article that we are reviewing today is called Occupational Therapy Consensus Recommendations for Functional Neurological Disorder. It comes to us from the Journal of Neurology, and it was published in 2020. This article is ranked 35th on our list of the 100 most influential OT-related journal articles. So the article begins with, what is functional neurological disorder? Functional neurological disorder is a common, costly, and disabling condition. While FND was marginalized in the 20th century, there has been a renewed interest in this disorder, catalyzed by improved diagnosis and treatment, as well as an embrace of the biopsychosocial model. In the simplest sense, FND is marked by connectivity issues where different parts of the brain have difficulty communicating with each other, leading to neurological symptoms. While people sometimes think of FND as a wastebasket diagnosis, there are clear rule-in signs, and this is not a diagnosis of exclusion. In our show notes, I am going to link to a paper that gives a really nice full update on the diagnosis of FND, and I definitely recommend you check out this paper if you have these clients on your caseload. Two important things for OTs to note from this section is, first, in the DSM-5, functional neurological disorder is used interchangeably with conversion disorder, but it is now widely accepted that functional neurological disorder is the updated term. And the second thing that's important for OTs to note is there is a large variety of symptoms that could be associated with FND. And the DSM-5 gives the following subcategories of FND based on how the disorder presents. So first, there's FND with motor symptoms, second with seizures, third with sensory symptoms, and fourth with mixed symptoms. So what treatment is recommended? Multidisciplinary treatment is considered the optimal approach. This can include neurological assessment, PT, OT, SLP, and psychiatric care. The specific evidence supporting any one of these treatments, occupational therapy included, is still limited, but OT shows strong face validity due to our biopsychosocial approach to care. An important step towards increasing OT-specific research on FND is to standardize our treatment of it, which leads us to this paper. So what was the intent of this article? In this paper, the author sought to develop a broad set of consensus recommendations to guide OT practice for people with FND. So, what were their methods? Following something called the Delphi method, data collection and analysis occurred in 4 key stages. First, 12 OTs from different countries who had extensive experience in F&D were invited to complete an online survey about assessment and then one about intervention. Second, a face-to-face meeting was held in Scotland in 2018, during which participants discussed and debated the data. Third, recommendations were drafted based on the meeting. And fourth, participants either endorsed each recommendation or provided suggestions. And this feedback process went on until consensus was reached. So let's look at these recommendations for OT. This is such a rich section. There is so much information in here. I really encourage, again, anyone working with this population to read it in full. But here are some of the highlights. The recommendations start at referral to OT. And the group suggested that OT intervention for FND is more likely to be successful if the client has some degree of understanding and agreement with the diagnosis, has agreed to the referral, and can identify rehabilitation goals, and understands that the initial focus of OT is to improve function. Looking at assessment recommendations, they provide this full 10-step structure that could be useful in guiding an initial assessment. I'm going to give you the high level of these 10 steps. There's a little more detail in the article. 1, begin with asking the person how their symptoms started. 2, create a list of symptoms. 3, clarify the person's understanding of the diagnosis. 4, ask the person about their medical history and any other health problems. 5, take a detailed social history. 6, gain a picture of their 24-hour routine. 7, determine if they have care needs and how those needs are being met. 8, ask about access to home, work, and/or school environment. 9, if applicable, ask about the impact of symptoms in the person's school or work environment. And 10, observe the person's daily activities. Note distractibility and variability of symptoms. The authors also recommend the following standardized assessments: the Canadian Occupational Therapy Measure, the Occupational Circumstances Assessment Interview and Rating Scale, the Worker Role Interview, the Model of Human Occupation Screening Tool, the Occupational Self-Assessment, the Adolescent and Adult Sensory Profile, and the Assessment of Motor and Process Skills. Headed into the treatment session, the authors highlight 2 overarching themes of OT treatment. 1, the importance of supporting self-management of symptoms, and 2, the value of establishing an internal locus of control, rather than placing control in the hands of clinicians and family members. The authors go on to provide detailed recommendations in the following area: goal setting, education, vocational rehab, aids and adaptations, splinting, and then symptom-specific treatments for functional motor symptoms, functional visual impairment, functional cognitive impairment, and associative or non-epileptic seizures, which are now called functional seizures. They also talk about common problems associated with FND and what OT's role is in supporting these. There's hypersensitivity, anxiety, fatigue and pain management, psychological trauma, risk management, and disability management. So hopefully that gives you a really good sense of what you will find in this paper. And we'll be discussing some of these treatments more in depth with Naoya. But headed into their section on concluding treatment, the authors say that discharge should not be framed as a conclusion of treatment, but rather the point at which the person should implement self-management strategies. The authors suggest a relapse and prevention plan that the patient can carry forward after discharge. And to create one of these, the following questions should be collaboratively considered. 1, what have you learned about the condition? 2, what makes your symptoms worse and what might trigger setbacks? 3, what are the most helpful management strategies that you have learned? 4, what were the unhelpful coping strategies that actually made it difficult for you to improve? 5, what can you do if you notice your symptoms and function getting worse? And 6, what are your goals for the next 3, 6, 9, and 12 months? Booking a follow-up appointment to review progress, troubleshoot issues, and reset goals is advised. So, headed into the conclusion, the authors re-emphasize that FND is a complex condition that has far-reaching consequences on physical and psychological health. Multidisciplinary rehab, including OT, is the current best practice. This paper provided OT assessment and treatment recommendations for people with FND, considering their journey of managing the acute stage and gaining support in the community. This paper provided so many details for us to draw on for understanding FND and assessing and treating it in our OT practice. But I also just left with so many questions about what this care looks like in real life practice. And I'm so thankful to have found someone who really specializes in this and similar conditions in his practice and has a work setting that really supports this gold standard approach to care that is multidisciplinary. And that is Naoya Ogura, OTD, OTRL. Naoya Ogura is an occupational therapist at an integrative outpatient neurological clinic called Reactive. He specializes in lifestyle interventions, which he studied at the University of Southern California. His specialty is in sleep management and autonomic regulation. At Reactive, he leads a hypermobility/dysautonomia program and also is involved in many of the functional neurological disorder cases. So without further ado, I will patch Naoya into this podcast. Welcome to the podcast, Naoya. It's great to have you.
Thanks for having me, Sarah. So excited to be here.
I am so thankful you're here. At the beginning of each year at OT Potential, we generate a list of the 100 most cited OT-related journal articles from the past 5 years. And lots of times there's like 2 on Parkinson's, 1 on MS, 1 on autism. And this year I was so surprised because there were 5 on functional neurological disorder, which is probably the most represented diagnoses on there, which is surprising, but double surprising because I didn't know anything about this diagnosis or disorder. So I'm so thankful that you're here to update us on this just exciting moment in FND. And I think a lot of us have a lot to learn about it. But before we get to all that, I want to start with you and your story. And let's start with how you first learned about FND. Like, is this something that you've known about for a long time? Did you learn about in OT school? Where did it come into your story?
Right. I mean, I was in the same boat as you, Sarah. When I first learned about FND, I had no idea what it was. I learned about it after I started working here at Reactive, but I didn't hear about it in school. I didn't read about it anywhere. I didn't know it was a thing. I thought functional symptoms in the sense of FND, I thought that just meant like impacting function. So I really didn't understand what FND was at all. But I learned about FND because a lot of our clients who come to Reactive have FND. And currently it is our biggest program. So we have the biggest number of clients who come here for FND compared to other diagnoses. But I think the way that we fell into FND as a clinic is we started noticing these patterns of symptoms in people who we were seeing. And some of the research kind of supports this too, where FND is the second most common neurologic diagnosis in neurology, like outpatient neurology clinics. So it's actually really, really common, just that maybe not as commonly noticed, not as commonly diagnosed. But we started noticing that people who we were treating for different symptoms, they were presenting really with signs that were consistent with FND and responding to treatment for FND. So we just started treating people, OT, PT, psychology separately. Then we turned that all into a program where it's integrated. Now we have yoga, Pilates, personal training. So as everything grew, I think we just got immersed in the world of FND, and I got deeper and deeper into the literature.
My understanding is that Reactive is like well known for your work in this area. And I'm curious, did this start with like a connection to a neurology group? Did your founder have a specific interest here? Like, it seems like there's FND clients all across the country and all across the world that don't make it into the clinic. Why are they making it into Reactive? And I guess what can we all be doing differently?
Right. Yeah, that's a great question. I do think I have to give it to the clinicians here. Like the founder, Julie Hirschberg here, super, super driven to learn. She's like just such a curious person. I think that's what really drew me to the clinic as a whole, because her curiosity to learn kind of impact the whole clinic. But the clinicians here, I think, being very curious about symptoms that just weren't adding up, given our understanding of things like PD or Parkinson's or MS or any other diagnosis. And people started learning more about it. Clinicians started learning more about it here. And then over time, I think what really makes Reactive unique in the world of FND is that we have a pretty well integrated program. We take more of a transdisciplinary approach to FND. So like I said earlier, occupational therapy, physical therapy, psychology, yoga therapy, personal training sometimes, Pilates sometimes. And a lot of the research around FND too is really supporting a multidisciplinary integrated approach. And I think that really does make a difference, because we'll talk about this more in a little bit, but FND isn't by any means a purely psychological condition, right? There could be certain presentations where psychology is a big component of why the symptoms are there, but rarely do you see a case where you just have to treat the psychology part and the person improves smoothly. I think there are so many physical components, sensory components, autonomic components. So having an integrated team, I think, makes a huge difference. That's what we do. I think that's what people are drawn to when they're coming to Reactive. And over time, I think the community builds, right? So once you start having good programs, good outcomes, people talk about it, they'll report back to their neurologists. We do a lot of continuing education too online, whether it's casually on Instagram or more formally through a Con Ed program. I think that slowly builds the network, because the network of FND treating clinicians, they're not that big yet. And so we have a pretty tight-knit community around that.
I feel like so often on the podcast, we talk about how like interdisciplinary approaches are the gold standard, but so rarely do we get to work in those settings where that's actually happening. How at Reactive do you make that a reality? Like, do your physicians just know to refer to multiple disciplines? Like, if someone comes in with just an OT order, do you push for more disciplines to get involved? Like, and do patients come and like see OT and PT like in the same hour? Like,
yeah.
What does that look like? I should know how this functions because this is a gold standard, but I've never gotten to talk to someone who actually works in this gold standard setting.
I think that's a great question, right? Because we all know that's the gold standard, but the logistics of how to implement that, I think, isn't always clear when you read about it, right? So we struggled with that a lot, actually. Like 3-4 years ago, we were doing a little bit more of a piecemeal approach, right? So people get referred maybe just for physical therapy, and they start, and then we try to get them into OT, and then maybe we try to get them into psychology, but there's already like a 6-week gap, right, from start of PT. So we actually revamped our whole process. And right now what we do is for FND or other diagnoses as well, the client gets referred by a physician. And typically the physician will recommend an integrated approach, but sometimes they might not mention that. But regardless of the situation, the person comes in for a free consultation. So this is when the client talks to a program director. So for their specific diagnosis, a clinician, and the clinician, OTPT, would talk to the client, get their medical history, get a little bit more about their goals, what has worked, what hasn't worked. And in that initial phone call, we propose an integrated program. So typically for FND, we're doing PT, OT, psychology, yoga therapy could be a big part of it as well. And typically for FND, we're talking at least 6 hours a week of outpatient neuro, sometimes up to 12 or more hours a week. And then we have that duration also determined at that point as well. So maybe 4 weeks, 6 weeks. And from there, we start scheduling. And the pros of this approach is that because we are able to kind of decide on that OTPT psych prescription ahead of time, when we schedule, logistically, we can actually start PT and OT and psych on the same week. So we have to eval at the same time. And then on a weekly basis, we have an integrated team meeting. So that's when all the clinicians and the wellness providers also come together to talk about the case for 30 minutes. That's built into the program structure. And I think that meeting actually makes a huge difference because that's when we're able to collaborate a lot more, talk about the different pieces of the presentation and how we can all treat it as a transdisciplinary team.
Do you accept insurance?
We do not. We are out of network with insurance companies. It's been a hard process to figure that out. There are, of course, like accessibility components, right? Like we want to make sure the treatment's accessible, but there are also limitations that come with taking insurance. And so right now we do issue super bills. So people either bill their out-of-network insurance benefits on their own. We also have a scholarship program as well. So we fundraise. We actually have a continuing education branch of Reactive, and so that also feeds into the fundraising. And then we actually do some student programs as well. So our doctoral students are great here. We have PT, OT, and psych students. So when the fit is right at the consultation, if we figure out, okay, like let's get you in for a student program, we might do that as well.
Mm-hmm. Well, that's all just so awesome to hear. I wish that our healthcare system wasn't in the reality where you have to like go outside of insurance to provide this gold standard care, but I'm so thankful that you all have found a way to do that. And that is just what we need in this area and in many areas is pioneering clinics who are figuring out a way to provide that best care for their clients. I'm so curious, as you look at these recommendations, they were put together maybe 5 years ago, and this is such a quickly developing area. How do they hold up to you? What stood out to you? What were your impressions of these OT recommendations for FND?
Yeah, my initial impression was positive. I like the
good,
article.
good.
I think any article on FND and OT, I'm like, yes, go for it.
Yes.
We need so much more research in this. So I was very happy with the article overall. I do think there's, like you said, more research coming out in the world of FND and more that could be updated. But overall, it was a positive impression. I like that they talked about the 24-hour approach. That's a big portion of what I do at Reactive actually is a lifestyle-based approach. So it was good to see that there.
Mm-hmm. Good. I read multiple articles about FND this week, but I still personally feel like I would have troubles explaining it to a client. I'm curious what kind of language you use when talking about FND, and then how you explain OT's role in treatment.
Yeah, that's a great question. So I think with FND, if you are a clinician, if you're meeting someone with FND in the clinic, I would always recommend that you ask them what their impression is of what FND is, just because that gives you such a good baseline in terms of how you might want to explain it and what kinds of myths you might want to address in the moment. But at its core, FND is a connectivity issue in the brain. So if you think about the brain, you have so many different parts obviously responsible for different function. And those different parts have to communicate effectively for you to be able to do anything, basically, right? But even movement, for example, there's going to be a connection between like an intent agency part of the brain with the motor part of the brain, with the sensory part of the brain. If those communications aren't functioning properly, if there's a disruption, that can lead to too much movement or too little movement, that can lead to weakness. So at its core, FND is a connectivity issue. Now, you might have heard of another common analogy for FND is that it's a software versus a hardware issue. It's now been slowly updating. So we do know in the research now that there are actually potentially some hardware, like tissue changes with FND. Nothing's been confirmed to the point of it being a diagnostic criteria, but it's not purely a software issue. based on the latest research, but I tend to refer to it as a connectivity issue. In terms of your other part of the question about the role of OT, I really do tailor it based on what the person really needs, right? But I tend to talk about how FND is a connectivity issue, and the connectivity in the brain can be impacted by so many different things, including things like the sensory system, things like the autonomic nervous system. And I'll explain a little bit more about those parts of the nervous system to the client based on what their knowledge might be, and then talk about how OT can help with regulation of those different systems to help with the symptoms. I do also sometimes talk about like an occupation-centered OT approach, right? So return to life, return to activities. I found that sometimes people come in and what they need to hear the first visit is very different, depending on the person's experience. So sometimes it's important that you talk about, the occupation and describing OT in that way. But a lot of times people come in with an FND diagnosis and not having a clear picture of what FND is, what the prognosis is, what the treatment plan is. So I do tend to lean a little bit heavier on the science side where, I'm validating the person's experiences, explaining what FND is, doing a lot of education around that, and then talking a little bit more specifically, well, if we regulate the sensory system this way, regulate your sleep so that your autonomic nervous system is also responding well throughout the day. If we're doing this and that, this is all going to help with your symptoms.
Do you have like handouts or websites you refer people to then that are trusted for you?
Yeah, there's a great website called neurosymptoms.org. I can send this to you later and can probably add it to the show notes or something. But it's written by Dr. John Stone, who is a leading researcher in the world of FND. A lot of the articles on FND are written by him and his team. But it's a great website. It talks about what FND is, different presentations, if someone has functional tremors or functional weakness. It goes into depth about all those different presentation, some treatment principles, stuff like that as well.
I'm curious for my own understanding. You probably wouldn't couch it like this to a client, but thinking of it related to other neurological disorders like POTS, or is it Ehlers-Danlos?
Ehlers-Danlos.
Okay,
yeah.
EDS. How is it similar and different from other syndromes like that? For myself, like I had such more familiarity with POTS because I dealt with some of those symptoms after my pregnancy. But I'm curious, I wonder if I'm typical of most people where I know a little bit about POTS. But hadn't heard of FND. Yeah, how are these similar or different? And what is there like a different approach that you're taking when an FND patient walks through the door?
Yeah, I think at its core, I think it's important to remember that FND is like any other condition in that there are things that we know about it and there are things that we don't know about it. And that's completely normal in a neurologic or any sort of condition, really. But sometimes I think FND, there might be a tendency where a clinician might think, okay, there's like so much that we don't know, hands go up and they go, we don't know what to do, or it's a mystery condition, right? But that actually leads to a lot of misunderstanding or sometimes medical trauma for clients as well. So I think in some ways it's important to think about FND like any other condition, but more specifically, though, there are specific things that are important to remember about FND that might be different from other neurological cases, especially in the article, they talk about some of this too. But a main one, for example, right, is the use of adaptations and how with FND, you might want to be mindful with how you recommend adaptations. The rationale behind that is some of these compensatory techniques might move the person away from the automatic movements that really help with the recovery of FND. I think it is situational, though. It's not that someone with FND should never use the wheelchair or anything like that, right? There are certain situations where Maybe the person needs that as a tool in the moment to access the community or feel more independent and safe. And there are also situations where people have FND and another condition like Ehlers-Danlos syndrome, and maybe they want to use the wheelchair for another condition that they have. But with FND, I think some of the things that are important in terms of movement and treatment that you do is that a lot of the internal focus on movement can backfire with FND. So if you're thinking about motor control, you can have two main ways to engage in movement. One is an internal focus and the other is an external focus. And an internal focus is when the brain is going, I'm going to reach for this cup. I got to make sure that my arm is straight. I got to make sure that my elbow is extending. I got to focus on my finger spreading. And all that internal focus on the body part basically feeds back into the FND. So if the person has a functional tremor or functional weakness, that can actually make the symptoms more severe in that moment. Whereas with FND, if you do more of an external focus, where instead of thinking about the body, you're thinking about the cup, and you're going to focus on tapping that little logo on the side of the cup. Or maybe you're doing a more of like a sport-based thing where you're using a racket, you're hitting a balloon. All these things can make it easier to access that automatic movement with FND. It's the case with other conditions too, like external focus works with other neurological conditions with motor learning, but with FND, it's definitely pronounced.
Mm-hmm. I had to read about that so many times in the literature, like encouraging that external focus, just because, I don't know, I had never heard of that. And that did feel like a big differentiator of what you would be doing differently as a therapist and thinking about when an FND patient or client comes to you. My last follow-up question on how these patients get to us. I'm just curious, in your experience, I feel like with POTS, people are getting diagnosed like more quickly. There's more knowledge about it. The clients haven't been on this horrible journey for years of being not believed. Is there a similar improvement in the diagnosis of FND? Have your patients been on a horrible years-long journey of trying to get this diagnosis? And have you seen that change? Is it happening faster that they're getting this diagnosis?
That's a great question, Sarah. I don't know what the actual numbers are, but what I do tend to hear from people that I talk with at the consultation, even for things like POTS and EDS, still like a long diagnostic history journey, and this pattern of being dismissed, right? Like, oh, this is just all anxiety, or this is just normal pain. Similar with FND, I think as people do go on a long journey, generally speaking. But I also do think there's maybe more awareness among different providers and more resources online, I think. A lot of people who apply, they get connected with a neurologist who is involved in the FND network almost, right? So they know where to refer to. And so I'm seeing a little bit more of that. People who research on their own too, I think definitely people are feeling more, in some ways empowered, but also kind of left on their own, right, to figure this out. And so people are leaning on online resources to figure out where they should go to next.
Mm-hmm. Yeah, when I was Googling the diagnosis, of course, you see like the Reddit threads, and just in what I was reading, like some of it was helpful and some of it was not helpful about the prognosis of it. And I can see clients coming in, with that long history and with this huge potpourri of knowledge that's both helpful and not helpful. Thinking about assessment, I liked how these recommendations kind of highlighted, here's 10 things you could walk through in an assessment. What did you think of those 10 things, and what do you do during assessment?
Yeah, I think the 10 steps were great. I think it's a good starting off point for sure. I think what I'm hoping people take away from this podcast is the importance of nuance in how you're talking about FND. I mentioned earlier too with the role of FND, role of OT in FND. Maybe your role is to help with sleep regulation or autonomic regulation, stress management, depending on your setting, of course. But But if you approach those topics without explaining why, if I go, okay, you have FND, how is your sleep? That experience can be very invalidating, right? Because the message that they might be receiving is, oh, like this is all coming from like bad sleep. This is all coming from stress. I'm causing FND, right? And these are things that people sometimes have been told, sometimes explicitly by their past clinicians, right? And so it's important that the nuance is there as you're talking about it, that you're really honing in with what the other person's experience has been going through the medical system and how their process was getting their FND diagnosis. But I think what the article mentioned about clarifying the person's understanding of their diagnosis and whether they are in agreement with it, I think that's a great place to start, getting the person's understanding of FND. Can they explain it? What kind of explanations have they been given? And can you clarify things for them in that moment? Whether they are in agreement with it, I can see that being a very nuanced topic as well. I think if I ask, hey, like, do you agree with it, point blank, sometimes people might feel a little shaky on it, right? Because maybe they've tried these different recommendations for FND and they haven't quite helped, or maybe they don't feel confident in the diagnosis because there was medical trauma going through the diagnostic process. So I think a lot of times it's not a simple yes or no. It's more about, well, how do you feel about it? What are you concerned about? What do you feel like people are missing? And sometimes that actually gives you a lot of great context, right? Because maybe there is an orthopedic component. Maybe there is a POTS EDS component. Maybe there's a sensory processing component that's more lifelong. So that will give you a little bit more context in how you might have that conversation. Another recommendation that was in the article that I would be mindful of how to implement is creating a list of current symptoms. So we talked about how an internal focus can feed into FND. And so it's important that you get a general sense of what's going on. And sometimes different symptoms respond to different inputs, sensory input, strategies. So it's important that you have that information. But you want to weigh your options depending on the tendency for hypervigilance or stress regarding the symptoms. Because if you spend 30 minutes of your intake just talking about the symptoms, that's likely to trigger at least some of the FND symptoms in the session. And at a certain point, it actually might not be giving you as good of an information, considering the cost of getting that information, if you will, because as you go through the list, you might also be feeding into this pattern of, let's keep track of your symptoms, like let's keep a log of your symptoms, and all those things can be actually things that you might want to do less of as the person goes through your program.
In your multidisciplinary setting, how do you coordinate not, I guess, just asking the patient the same thing over 3 times? What does that coordination look like?
Yeah, so a lot of the notes from the consultation is, I think, what we go off of, what I go off of as a clinician. So the history is mostly there. We also have an application. So it's actually an application the person writes. Then we have the consult notes. So we try not to have the person repeat their story like 5 times in the process. But I usually, if I'm not the person who did the consultation, I'll say, I read the notes. We also have a meeting usually before the program starts. So the consultation therapist would meet with the treatment therapists and they debrief. So that gives you a lot more context. But usually I'll tell them, hey, I talked to the person who did your consultation. I read the notes. I do have a few things that are OT related that I want to ask. And so I don't go through the whole medical history, but I'll be able to gather information that wasn't covered in the consultation.
I love hearing about this gold standard of care that you all are doing. When it comes to treatment, what does a typical treatment look like for you? Like, I hear that you're, of course, tailoring and covering all these different areas, but do you have an answer to what a typical treatment would look like?
Yeah, I think there maybe isn't like a typical, but we do have a framework that I think guides the session. So At the consultation, we call it the pie chart. It's literally a pie chart of the different systems of the body. So we have a motor control, we have a sensory system, psychosocial and cognition, lifestyle, the autonomic nervous system, and physical limitations. And so at the consultation, we basically figure out, well, given your story, which part of the pie chart is the biggest contributing factor to your symptoms, which ones are the biggest barriers to your goals. And that kind of guides the treatment sessions, right? So if the sensory, for example, is a huge part, the person goes to a grocery store and the symptoms are triggering, there's a lot of tactile components to it. Then you might start there, right? So maybe you do a sensory profile, maybe you talk about sensory strategies. If the lifestyle component is the biggest slice and the person having insomnia on top of the FND, or maybe the person is completely fatigued out because they have all these different responsibilities at home in addition to managing their health. And so maybe you take more of a routine-based approach, or maybe you do CBT for insomnia. So it really depends on what the person needs, right? But I think if you have a good picture of, well, what are the different systems at play, which ones are impacting the symptoms the most, that'll guide the treatment session and also the sequence of sessions.
Is this a framework that you all came up with?
I think it was, one of I think Julie, our founder.
Good job, Julie. That's awesome.
I know. I think she worked with another physician, I want to say, to come up with this pie chart, a neurologist.
Yeah, that's super helpful.
Yeah, I like it. I really like it. It gives you an easy way of prioritizing because, it gives you the answer of, right, should we start with breath work or should we start with the sensory profile? Should we work on external focus, right? Like it really gives you an understanding of what is going to be the most helpful.
Yeah. I always think of, I had a cancer rehab therapist on the podcast, and she also started with just like a list of areas that she could work on, and then was guided by what her patients chose were most important to them at that moment. And sounds like you're doing something similar with your pie chart. Tell me about the 24-hour approach. I saw that a lot in the literature, but I was also feeling like I didn't have immediate familiarity with that, which maybe I should have. Can you tell me about it?
Yeah, of course. Well, so the 24-hour approach, I have my own background and spin on it, maybe. So I am trained in lifestyle interventions. I went to University of Southern California, where they developed lifestyle redesign. And got some additional education around that. So I'm coming in from like a lifestyle change angle with FND sometimes as well. But long story short, a lifestyle intervention in the context of OT, you are working on different health management habits, right? So you're thinking about how sleep, how eating routines, stress management, time management, all these things, exercise as well, all these things impacting the person's physical, mental health, and how their conditions also impact those routines, right? Because FND or other conditions are going to impact these habits and routines. And for me, a 24-hour approach, what that means is you're not just looking at this one sliver of the person's day when they come into your session to make sense of their condition, right? You're looking at the whole 24 hours. You're looking at their sleep. You're looking at their blood sugar regulation throughout the day. You're looking at their hydration, especially if someone has a condition like POTS, right? Or some sort of dysautonomia where it might be playing a bigger role. And you're also looking at the psychosocial component of the routine, if that makes sense. So what is their living environment? Who are they living with? What are their family members' understanding of FND? What are the interactions like? Who's helping them? Who's not helping them? All those things, I think, come into play because the nervous system, the FND is there 24 hours, right? And so if you work on it in session, but the techniques aren't being carried over into the home, it's just not going to have the same effect. And so getting a better picture of what the person's doing outside of the sessions is super important because especially too, sometimes people say, hey, like when I come into the clinic, I use these strategies, I use these tools and it works, but maybe at home, they're not getting the carryover. And like with any sort of neuroplasticity principle, right, you want that repetition and dosage. So the 24-hour approach, I think, starting with what is your typical day, right? Get that understanding. Make sure you're asking good questions about the family, living situation, hobbies, things that they're doing outside of health management. All those things will give you a lot more understanding in terms of where you might intervene as an OT.
I relate to that a lot. Like after my second pregnancy, I would wake up every morning and dry heave. And I would focus so much on like, what was I doing as I got up? But I didn't have success until I looked at the night before and thought in that 24-hour cycle of what I could do to disrupt that. And that's just such a helpful and needed framework, I think, of, thinking about these routines and habits and how they impact the day. And it's just all interconnected. So that's super cool that you're doing that.
Yeah, I think what's interesting too about the 24-hour approach is that sometimes when people are looking for patterns with FND, it can be really challenging, right? Because maybe you haven't even thought about, maybe you didn't know that an autonomic nervous system was a thing, right? But you're given this diagnosis and you're trying to figure out the patterns. But initially, maybe you don't see a pattern because you're only looking at, the 15 minutes leading up to an episode. But if you zoom out a little bit more and you're thinking about, well, how was my blood sugar that day? How was my stress level leading up to that hour, right? How was my sleep the previous night? What conversations did I have? Some of these information, some of the pieces of information can be helpful in understanding our own nervous system. Because FMD too, in some ways, you can think of it as your nervous system trying to communicate with you, right? The nervous system is going, hey, this is too much. I can't do this. This is going to overwhelm me, right? So these symptoms can come out. And so by understanding our own nervous system better and by knowing what to listen for, do I need to rest? Do I need to pace? Those things can help a lot in certain types of FND presentations that you might see in the clinic.
I could ask questions about treatment forever. I'm going to limit myself to 2 more questions. Are you leveraging health trackers a lot? Thinking about that nervous system education, is that helpful or not helpful? Thinking about how that could create an unhelpful kind of focus. Or maybe it could be helpful. I don't know.
Yeah, it's situational. Generally speaking, I don't lean heavy on the trackers. If I do use some sort of tracking, I preface it with, well, we're just going to track for a week, or we're just going to track for 2 weeks, and explain my rationale there, right? That we don't necessarily need to be constantly vigilant of what you're doing. But context that I tend to use tracking, biofeedback for stress management tends to be a great tool for most people that I've worked with. Insomnia, like if someone has insomnia, a sleep log is going to be helpful. You might do that. Although with sleep, based on my understanding, some of the latest research is still saying that you don't really need like a sleep tracker that you wear. A pen and paper log is still effective enough. And some of the sleep trackers, sometimes too, they give you numbers that maybe not are as accurate, and that can feed into the worry, right? Of, I felt like I got 7 hours of sleep, but this is saying 5.5, and it gave me a score of 3 out of 10. And so that can feed into some stress and worry around some of these things. So I would say situational. You work with the person to make sure that it's actually a net gain versus leading to more stress and anxiety.
Mm-hmm. I wanted to for sure ask about functional seizures as well. I know that's a somewhat common symptom, and I can just see that being a big reason where people really pursue the diagnosis and get into treatment. I think I just personally hear seizures and I don't feel totally comfortable with what I would provide as an OT. And it makes me nervous, I guess, or just to be totally frank. What advice do you have?
Yeah, I mean, that's how I felt too, right? I think
Okay.
the idea of a seizure happening in session would have freaked me out as a new grad, or even, after practicing for a while. But a couple things, right? So with functional seizures, when they happen in session, I've definitely had multiple happen in my sessions. How you respond in the moment impacts the symptoms as well, right? So if I'm freaking out, and if I'm rushing and yelling, and if I'm like, oh, should we call 911? That's just going to feed into the dysregulation happening in the moment. So the first step as a clinician is making sure that you you feel comfortable, you have your regulation tools. Part of feeling comfortable might also be making sure that you know what the diagnostic process is like for FND. And if the person has gotten a video EEG, for example, and making sure that the diagnostic process has been clear to you. You having confidence in the diagnosis is also important. And once you have that foundation, then I think it's a matter of the 24-hour approach would be a big component of it. Psychology referral would also be a big component of it. A lot of research around functional seizures, especially in kids too, really strongly recommend a CBT approach or some sort of psychology approach. And like I said earlier, with functional seizures, you might want to really focus on how the nervous system is paced throughout the day. So, are we doing good breaks, physical breaks, mental breaks, emotional breaks, and helping the person understand how to listen to their body throughout the day.
In the article, they provided, or they talked about discharge, and they talked about making a plan and like 5 questions you could ask to kind of set the stage for discharging, but moving into a self-management phase and knowing it might be helpful to come back to therapy. What does discharge look like for you all? And did you find the recommendations in there helpful?
Yeah, the discharge plan for us is, it depends on the case, of course, but we generally make a discharge, like a program summary for the client. So this is a list of things that we've tried, summary of what we talked about in sessions, and also some recommendations for next steps. So this is a document that the OT, PT, psych, yoga therapy, whoever that was involved in the care writes. And that kind of covers a good chunk of information that the person might need for the next few months or so. And with our programs, we typically do have a taper plan. So maybe the person does an intensive for 4 weeks, but maybe we continue with 3 disciplines for another 3 weeks, another 4 weeks. And so sometimes it's a little bit more of like a gradual ramping down as the person returns to life. Sometimes we'll do more of a like a wellness discharge, if that makes sense. So wellness meaning like yoga therapy or personal training or group classes. We also have an online membership where people with FND can join for support groups and other classes. And so sometimes we'll coordinate that way too, especially if people are coming from out of state. Because as you know, we can't treat across state lines over telehealth. And so making sure that we have a wellness team at Reactive can support the person. And then the final component being talking to another clinician if the person's going to continue care outside of Reactive. So whether it's a PT or an OT, ideally having them join for one of the meetings that the clinicians have so that we can talk about, here's our approach, here's what I found to be helpful, here's what the person wants to work on, what are your thoughts? So we can get that handoff of the case more smooth.
I have just loved hearing about this program that you're a part of. Definitely seems like you're doing something innovative and needed, and I guess just exciting to see this gold standard care delivered. I know that not enough patients with FND get to an OT, get to multidisciplinary care. How do we change that? How do we move forward? I guess specifically, what do we need to do as OTs?
Right. Yeah, I like the framing there, Sarah. What can we do? There's so much that can and should and will eventually happen. But as an OT, I think what you can do is to learn how to recognize signs and symptoms of FND. So the article, I forget if the article talks about it, but there are other articles that go over the signs and symptoms of FND. So are you noticing a lot of variability in the symptoms, for example, or is there distractibility in the symptoms? Are the tremors entrainable? By looking at these FND signs, you'll be able to say, okay, like this fits within what the doctor explained, or this fits within the diagnosis that you were given, or there might be something else that could be happening. And when you start noticing those things, then you can actually refer them back to their neurologist and say, hey, like I noticed that there are some symptoms that might be helpful to discuss with your doctor. And you can coordinate with the neurologist if you have a working relationship with them. I think getting more people clear diagnoses around FND would be helpful. And the second thing I think as an OT that you can do is to really start practicing how to talk about FND when people come to you. Because when you are able to provide that good care, people will talk to each other, right? I think as with any condition, there could be like a strong community, right, among people with FND. And we see this a lot with parents too, like parents of children with FND. They have like a support group in different parts of the country, right? And if you can really show them that, hey, I know what I'm talking about, I know what's supposed to happen, I know what to look for, that can really start building trust that OT can be helpful for treating FND, and that the word will gradually spread. And once you build that trust, I think people come to OT.
Mm-hmm. Yeah, I can really see a place for OTs in whatever system that they work in, being a lead on FND, a go-to on FND, just being a healthcare provider who's knowledgeable about this condition. It seems like there's huge gaps, and that's a role that OTs could step into. I have learned so much today about FND, about your approach. I just have just loved hearing about it and what you're up to. What's a closing thought you want to leave us on today?
Yeah, a closing thought for me for people with FND. I think if you're a clinician getting into treating people with FND, is to really, really listen. Sometimes my evals are mostly just listening to their story, right? Because FND can be a very scary condition. If it takes you years to get a clear diagnosis, and sometimes people are given the wrong diagnoses, right? So maybe they're told they have ALS, or maybe they're told MS or Parkinson's, and it can be a roller coaster ride until they get to an FND diagnosis. And sometimes they're given the diagnosis and then told there's nothing that we can do about it, or that's the impression that they get from the doctors or the therapists. And they can feel very, very left alone. And the symptoms can be really, really intense. And so creating a safe space where you listen to them, where you validate them, where you don't just go, well, that's coming from stress. That's just this. You really have to validate and listen. Sometimes people have questions like, is this all because of my ankle injury from 20 years ago? And maybe in your head, you know that's most likely not. But instead of just going, no, it's not, you might take a minute to listen. Right? Well, tell me what makes you think that. Tell me what are the symptoms. You just want to make sure that you are addressing all these pieces that come up with having a condition that's not well understood, because that can lead to a lot of spirals, right, of worries and uncertainty. And a lot of clinicians are uncertain sometimes interacting with people with FND, and that uncertainty translates, right? And so being able to create a space where you listen, you validate, you make sure that the person feels that they're listening, that you're listening to them. I think that would go a long, long way, even if you're not feeling 100% comfortable with FND. If you just listen, that will guide your treatment.
Well, you are doing such important work. I can just, in hearing you talk today, I'm like, I can hear this incredible skill set that you've built around treating this population and other neurological conditions. And I'm just so thankful that you were here to share with us today. Thank you so much for the time.
Yeah, thanks for having me, Sarah. I love talking about FND, so this was really fun for me.
Wow, you all, the information in this course has me looking back over my caseload and the people in my life and really seeing the helpfulness of understanding FND and seeing just the need out there for more people to get to OT care. In the OT Potential Club, we will have links to assessments and supplementary reading, along with hopefully we'll have some handouts for you so you can continue to feel more confident around treating this disorder. And I also want to highlight that I was just really inspired by the model of care at Reactive. And this episode felt like a call to action to really consider what providing the gold standard of care could look like for whatever diagnosis you are passionate about. And as always, I want to hear your thoughts on this episode. If you are a casual listener, we would love a review from you. You can now review us on Google from our homepage, or we always appreciate your comments on our YouTube video. But the best place to really discuss the implications of this episode is in the OT Potential Club, and I will be watching for your comments in our forum. The OT Potential Club is also where you will go to earn a CEU certificate for your time today. So what you are going to do next is head to otpotential.com and either sign in or sign up for the OT Potential Club. Once you are in there, you can take a 5-question test, and when you pass, we will generate a certificate for your time today. Okay, I want to thank you so much for joining us. I hope this podcast helps keep you informed and inspired as an OT professional. Take care, and we'll talk next time.